Hello there, my name is Sam Feltham and I'm the Director of the Public Health Collaboration. Now, before we get into this absolutely brilliant panel, we wanted to thank Dr. Jen Unwin and Heidi Giaever for their leadership and voluntary work within and beyond the PHC to build awareness for food addiction. For more information about their work, get in touch or even get involved, please go to the website www.the-chc.org or email contact@the-chc.org. Thank you very much. Enjoy.
Thank you. Hello? Yes. Can I first thank you, Georgia? Great presentation. And Susie, thank you for some beautiful slides. Very thought-provoking and helpful as a start to this conversation. Sam, thank you for this opportunity to have this panel for me to talk to amazing people with lots of experience in this area of food addiction. And thank you for the introduction, Georgia. I say food addiction, but actually there is no such thing that can be diagnosed today, because a couple of years ago, when we tried to suggest to the WHO's ICD-11 committee that this should be recognized as a disease, they rejected our 206 papers, scientific evidence papers, to actually do so. So today, we cannot actually diagnose according to anything, either in the DSM or in the ICD. Sam introduced me as working in the area of nutrition. I'm actually a chemical engineer, so forgive me for that. I've spent most of my life in international business. But some years ago, I retrained in nutrition as a result of my own health challenges, and that's very relevant to why I'm here today. Specifically, it looked as if I was following in my mother's footsteps and heading for early onset dementia. It wasn't dementia, as tests showed, and as I Googled myself, this is a number of years ago now, I realized that it was actually my diet, and it turns out a typical diet for a food addict, consisting primarily of sweet foods. Now, I realize now from what Georgia said, I was going to say my brain was being fried with sugar, but actually was being caramelized with sugar. And at the same time, it was being starved of fats. But I was on nobody's radar because I was never overweight. So I'm very passionate about this subject, but without further ado, I should actually welcome my panel, who are all equally passionate, I think, and probably much more knowledgeable than I am on it. So without further ado, Georgia, I'm going to start with you, and I want to add a little bit to what Sam was saying about you. So while you were at Harvard University Health Services, you were the first, actually, to introduce nutrition-based therapies as an alternative to psychiatric medication. And you developed the first medically accredited ketogenic diets for mental health clinician training program, in which you teach practitioners of all backgrounds to incorporate metabolic therapies into their care of people with psychiatric conditions. And in 2021, you co-authored the first inpatient study of the ketogenic diets for serious mental illness. And in 2022, you were actually honored. You told us about the Bazooki Brain Research, and you were actually honored to be the recipient of their first annual Metabolic Mind Award. So welcome, Georgia. Thank you. Dr. Ali Ibrahim. Dr. Ibrahim is a consultant child and adolescent psychiatrist specializing in eating disorders, with research interests and groundbreaking publications on the metabolic and neurobiological underpinnings of eating disorders. Dr. Ibrahim has experience of working with patients across their lifespan and across the severity spectrum of eating disorder presentations. And Dr. Ibrahim, as many of you will know, is also a much appreciated member of the Public Health Collaboration's Scientific Advisory Board. And a couple of days ago, I'm really excited to say that he was appointed to the position of clinical lead to join me in the leadership of the Collaboration for Kids, CFK, also known as the much needed antidote to KFC. Thank you. Welcome. Welcome, Ali. Then we have my good friend and colleague, Dr. Jen Unwin. She is, as you all know, a consultant clinical health psychologist, past chair of the UK Association of Solution-Focused Practice, winner of the British Psychological Society Karen Ellett Lifetime Achievement Award in Clinical Health Psychology. Jen has spent her professional life interested in the role of hope in chronic disease and how it can be used to bring about behaviour change. Her insights team up perfectly with her husband, Dr. David Unwin's interest in bringing about drug-free type 2 diabetes remission. So for more than 10 years now, they've been running group sessions in primary care to achieve just that, and more than 120 patients. I think you gave us 129, yes, already, well done. Both of our favourite doctors in the PHC were featured in a BBC TV documentary, The Truth About Carbs, that was seen by 3.7 million viewers. And Jen has written a book, A Fork in the Road, which underpins a lot of what we're going to be talking about today, specifically to help people with food addiction, and together with me is part of the team developing our food addiction resources here in the PHC. Welcome, Jen. I'm mentioning her. And then the lovely Claire Snowdon-Darling. Claire is the creator of functional kinesiology and the head of the College of Functional Wellness, an accredited international college specializing in the training coaches in menopause, hormones and diet. So a little bit of a different perspective, which is very exciting. Claire is regularly featured in the British press discussing these topics, and she has been in clinical practice since 2007. So welcome, Claire. So we do have a lot of questions, subjects that we want to cover, and we have listed them here. We want to start with, I think with you, Georgia. There was yesterday some reference to, I think Ben made some reference to us about people being addicted to being full. David, you talked to us about the probability of compliance being related to food addiction, and you gave us a beautiful introduction to this subject, of course. So, can you just tell us a little bit about how food addiction is presented in clinical practice? What do you see? And if I can just add to that question, because it's not actually recognized as a formal disease, is it treated? You know, are people turned away? And if it is turned away, what do we need to do about it?
So at least in my practice, the way it has always presented to me as a psychiatrist is people will come in and say that they have trouble controlling how much they eat. They really think they have trouble with binging. And so they're overeating, they feel out of control, they feel really embarrassed about that and really hopeless about it. Sometimes it takes them a while to bring it up, but it's usually something that they think of as something wrong with them, rather than something wrong with the foods that they're eating. So there's a lot of shame around it, and it can take a while for people to get to it. But there are a couple of things you'll notice. So one is often that people's mood is often unstable. It's not really bipolar disorder, just some mood instability. A lot of ups and downs throughout the day, a lot of fatigue, and just constant preoccupation with food, struggling to control that, and sometimes being more successful than others. What you also see very frequently is unstable weight. So weight going up and down, repeatedly losing 10, 20 pounds. They've got 4 different sizes, 5 different sizes of clothing in their closet. And so it feels, they really come in saying that their eating feels out of control. So for me, you may have detected that I'm not a huge believer in the DSM, and so I don't really rely on the DSM to inform my work. I mean, insurance companies do need often they want a diagnostic code, they want an official diagnosis. I don't really care if it's in the DSM or not. I still will just try to help people with whatever they're bringing in, because a lot of people don't fit neatly into any categories. If it were in the DSM, that would help it would make a big difference, because not everybody practices like I do. Some people really need to see that and want to see that to feel confident that they want to feel like they're making a real diagnosis and that they're standing on some solid ground there. I personally, just try to help people with whatever they're coming in with. But I know that most of my colleagues do not think that this is a real condition. And so I think that those of us who are here and are maybe the exception rather than the rule in terms of understanding that this is something that causes a lot of suffering for people and a lot of health problems for people too.
Thank you. I don't know, Ali, would you like to add a little bit to that? I was just wondering, on the basis that we are the exception here, and that people aren't maybe dealing with it as an issue in itself, do we just leave it like that, or what do we do? Do we start now, even though there isn't a formal diagnosis?
Oh, well, I think, of course, we need to start now. I mean, it's going to be, it's very difficult to leave a disorder untreated. I do think it exists, and I do think that, as you say, it's the exception. We are the exception rather than the rule, but actually it's very difficult to treat. And I think one of the things that does need to be acknowledged, to add to what you were saying earlier, is that a distinction needs to be made between the 2 components of the addiction, which is the cognitive preoccupation and the behavioral component. And the reason why that distinction is really quite important is because, of course, he was talking about the shame and the guilt associated, and I see that predominantly with eating disorders. I don't actually see in my service patients presenting with addiction, probably because we're not screening for diagnosing and offering any treatments. Otherwise, I potentially would have, but I think because of the guilt and shame associated, people don't readily present. I think that one of the issues is that there's a dilution and dispersion amongst different services. So although patients might not present directly, I think it's the metabolic consequences that result from that lead them to be presenting to different services. But then, obviously, if you're not looking for that, you won't find it, which is why I say it's quite important for all doctors across the board and all healthcare professionals to be aware of and to be addressing this issue. But it is really quite important because it has an impact on the entire body as well as the mind. But I think the distinction between those 2 components, the cognitive component and the behavioral kind of ramifications of it, is really quite important. And if you ask anybody that's experienced addiction, they'll probably say that the cognitive preoccupation is the thing that affects them the most and that leads to the most kind of impact in terms of the quality of their life and impact on their ability to function day to day.
Yeah. Thank you. Jen, I don't know whether you, because of your work with diabetic patients as well, the presentation that you see in clinic.
Yeah, very, very similar to what Georgia was saying, really. And of course, it's David who sees most of the patients at sort of firsthand. And I think the important thing is what Ali was saying is that doctors, because we didn't know about this idea, we weren't looking for it, we weren't asking, we weren't recognizing. And David would certainly say that. It's only really in the last few years since we've been thinking about this as an explanation for why, despite the fact when you've given people the advice about the nutrition and the diet and they're doing so much better, they've reversed their diabetes, they've lost an incredible amount of weight, they feel better mentally, as Ali was saying, still they're finding it hard to sustain eating in that way. because of all the things Georgia mentioned about the society that we live in, and this perhaps us not understanding it as an addiction. So this kind of a little bit's not going to hurt you, and then we see people going into these repeated spirals of sort of relapsing, and then being even more ashamed that they can't control that behaviour, even more hopeless, which is, of course, you know, what I kind of focus on. So I think if we, so Georgia was saying, it walks like a duck, it quacks like a duck, it's a duck. There is a thing that's food addiction. I think if we can educate everyone, as Ali says, about the symptoms and how to recognise it, and then how to talk to people about it, that's really the foundation of where we can go from there.
Yeah. Okay. I'm going to ask you to yes, and I'm going to give you a question that you can hook it onto. May I just?
Well, just a quick additional comment about what Jen was saying, because I think it's quite important. In a lot of patients that don't respond to, you know, conventional interventions, or even, you know, low carbohydrate or ketogenic interventions for things like, you know, for example, obesity and so on, it may be that that's the reason. Sorry. And so addressing addiction as a component might actually be the thing that, you know, changes. Yeah.
So while you have the microphone, could you? Well, I think we're going to move on to the next subject, very closely related, because eating disorders, of course, are recognised. So can you, Ali, from your experience, give us a bit of insight into the similarities, the differences? You know, people talking about binge eating disorder and bulimia also being features of food addiction. And also make a connection here where the question that can dietary restrictions such as a ketogenic diet, can that actually lead to or worsen eating disorders?
It's a really interesting question. That I think is an important question. In terms of the similarities and differences, it depends on how we're looking at it. So viewed through the traditional lens of psychiatry, we can look at, you know, the manifestations, the symptoms, but I don't think that that's good enough. I don't think it's adequate. So, you know, there are similarities in terms of, you know, the preoccupation cognitively, the overconsumption, the impairment functionally, and I think, yes, there's similarities. But as Georgia was saying earlier in her talk, that if we go through a list of symptoms, it doesn't really give us, you know, very much in terms of a biological understanding. And I think that if, you know, viewed through that lens, through the metabolic lens, if we're looking at, you know, the fact that there may be a unified concept that's similar to both as a same pathway that's essentially leading to the manifestation of the disorder, that's probably a better kind of rubric to view eating difficulties in their totality, and indeed psychiatric conditions. I think sometimes it's unhelpful to make those arbitrary distinctions between what may be, for example, bulimia or binge eating and addiction, although there are some differences in some of the ways that, you know, some of the behaviors and some of the symptoms. For example, you know, purging or over-exercising may be more a pertinent issue, for example, in, you know, bulimia compared to addiction. So I think there's some similarities and differences, but I think the other component that needs to be taken into account is that there has been an evolution over time in the nature of eating difficulties that have happened in parallel with the changing food environment, and that does need to be taken into account. I mean, in eating disorder psychiatry, we've kind of, you know, we dealt with anorexia for a long time without having then, you know, bulimia coming on board and binge eating disorder, and now, you know, even more disorders, and obviously more recently, you know, addiction-based disorders. And I think that there's a component of, you know, the changing food environment, and some of that, of course, is the nutritional piece, but a lot of that also is the environment itself and advertising and cues. And so that's quite important. The other really interesting question that you asked is about whether any form of dietary restriction, as it were, including the ketogenic diet, which I don't view as dietary restriction. But that being said, there are elements of what you might have consumed before that you would restrict, and so would that then exacerbate an existing eating disorder, or bring to life, an eating disorder for somebody who's got the propensity? And I think it's a really important question. I think if we're stepping back from this and asking whether there's an association between dietary restriction as a concept, restricting, and the risk of having an eating disorder, then I'd say absolutely yes. The more common form of restriction is restricting dietary fats and protein. And that's what I see in practice on a daily basis in most people that experience eating disorders. In fact, I'd say very few of my patients that I've seen with a kind of restrictive eating disorders, especially at the severe end of the spectrum with anorexia, very few of them haven't dabbled with some form of restricting dietary protein and fat. And the majority of them have been or are vegan, and I think that's a really important point that you raised. So dietary restriction, absolutely yes, in that context. I think the concept of restricting any having dietary rules or restricting any aspect of your diet can be cognitively impairing for some people, and some people are able to manage moderating certain amounts of foods that may or may not be compatible for human health. And I think the conversation then needs to be had about offering options and being transparent about the risks and benefits. But some people will actually agree to going ahead with having foods that they know to be risky for their health. Yeah. And I've certainly worked with patients that would have that preference. I think then the question would be, what impact will that be having on their metabolic health and consequently their brain health, and how that then might impact on their psychiatric health? And so I think that's the kind of conversation that needs to be had in terms of what may be short-term benefits of not feeling restricted, but then foregoing the long-term benefits of stabilizing metabolism.
Yeah. Thank you, Ali. I'm going to pass, if you could pass the microphone to Jen. The distinction here now, bringing us back to food addiction as it is, and the current treatment that we're suggesting for food addiction. Talk to us a little bit about the fact that moderation therapy actually doesn't work, and abstinence really is the solution that's offered here.
Yeah. So if it walks like a duck and quacks like a duck, like it looks like the behaviours and the cognitive preoccupation maps very closely onto an addiction model, then obviously we do know quite a lot. There's quite a lot known about addiction. Addiction medicine is a sort of well-known field. So the logical the logical model to test out would be the abstinence model that we know works with all other addictions. Of course, just as Georgia pointed out, we do have to eat. We can't not eat. But the point is not to eat one's drug foods. And those are reasonably unique to people, but also have these common features. And when research has been done, the addictive foods that people talk about being unable to control are, on the whole, ultra-processed foods, with a few small exceptions for those of us who are end stage. So abstinence has to be the key. And of course, in our study, that's what we were testing out, really, was educating people about all the things we've been talking about, and suggesting that they understand their own drug foods, which foods for them can they not, that they got these preoccupation with, and the cravings and the compulsions to eat, and then to exclude those foods from their diet. And so it's a bit like, how low do you go with carbohydrate? It depends on the individual and what goals they're trying to achieve. And it's the same, I think, with people with food addiction. It's not that you have to exclude, everybody has to exclude all the same foods. It's those individual foods that they can't moderate that you have to help and support them to, and understand why that might work, experiment and see how they feel.
Yeah. Thank you, Jen. And Georgia, I want to maybe continue on the treatment options here. So taking both those two perspectives into account, helpful treatment options, how do we ensure that it doesn't go wrong? Any thoughts on that?
Yeah, so, I mean, obviously, the cornerstone of my work is ketogenic diets and low carbohydrate. They're not the only diets that I use in my practice. I use lots of different types of diets, but that is the cornerstone, and I think, in my experience, the most powerful intervention for people who feel as though their appetite is always out of control and that they're always thinking about food, is to try to calm down the hormones from within by eating differently, eating in a way that's going to regulate those appetite hormones better and stabilize brain chemistry and stabilize brain energy. And so I do use ketogenic diets in my practice, and I found it really, really powerful and helpful for people who are willing to do it. And so the concern, and I appreciate how nuanced and how interesting and how complicated the question of, if somebody comes in and they're, who has an eating disorder history or has or even has an eating disorder currently, and you're asking them to restrict a certain, restrict carbohydrates, is that going to trigger or awaken the eating disorder? And I think that, at least from my perspective, that just about any dietary intervention has that risk, because as Ali was saying, that every dietary intervention involves some form of restriction. So vegan diets, vegetarian diets, Mediterranean diets, paleo diets, they all require some sort of addiction. And so how are you going to do a dietary intervention if you're not asking the person to change their diet? So I think, and so there are people with OCD tendencies, perfectionistic tendencies, eating disorder histories, that are just going to be more prone to taking just about any intervention you recommend to an extreme, an unhealthy extreme. But by and large, I found the opposite to be the case when I'm using ketogenic diets with people who overeat, is that they feel more in control and less eating disordered than they ever have before. And so that's the clinical experience on the ground. So theoretically, I guess it's interesting, but there's no research paper showing that ketogenic diets have ever triggered an eating disorder. And I'm not saying it can't happen, I'm just saying that's a risk with any dietary intervention. And so how do you prevent it from going wrong as you have a conversation about, about the person's relationship with food, and what does it feel like to them to think about, reducing carbohydrates? Because also, as other people have said, especially what Ali were just saying, people with anorexia, for example, I know we're not talking about anorexia, we're not talking about ketogenic diets for anorexia, but people with anorexia, I've never met a person with anorexia who isn't addicted to carbohydrates. They steal and sneak and think about carbohydrates constantly because they're hungry and they won't eat anything else. And so they think about carbohydrates, they're low in fat, they're clean, and they're very, you can control exactly how much. Anyway, I'm getting off topic, but I think that it's teaching people that carbohydrates, at least that the right forms of carbohydrates, that the wrong forms of carbohydrates could be actually feeding that eating disorder and making them feel more out of control and making it harder for them to control their weight, which so many people who overeat are trying so desperately to control their weight. And this is a much more effective way of doing that than limiting fat and calories.
Yeah, thank you. Wonderful, wonderful answer. I want to move away from diet for a moment. Claire, is there anything other than diet about dealing with food addiction? Is there a hormonal focus here that you can give us?
Yes, but it's going to come back to diet. Because as soon as we start looking at, we've talked about the insulin, and obviously Georgia just alluded to the internal hormones that drive our behaviors. But as soon as we really start drilling down into the connection of things like cholecystokinin on gut motility, and then when the gut motility slowed down and now we have a propensity to small intestinal bacterial overgrowth, when we're in this place with those elevated lipopolysaccharides now in free fall around our body, absolutely we're having this huge hormonal effect that's now going to drive behavior change. So it's always going to come back to diet whenever we're talking about hormones, because we can't take that away.
Lovely. Great. Jen, I want to come back to you. Talking about different types of diet and talking about the kind of harm reduction process that we talk about, maybe primarily with when we're helping people with weight loss and changing their diet over time, and particularly with diabetics, and suggesting artificial sweeteners. What about that in connection with food addiction?
I think the ultimate goal with food addiction has to be abstinence from sweeteners as well. So that's always the place that you're going, is to this sort of real food, as you always say, as nature intended. And it's been in the news again, hasn't it, recently, about the potential harms of sweeteners. However, yes, in a sort of harm reduction model, you may well encourage people, or you might suggest that if it's going to work for them, rather than going straight from a very high sugar, high refined carbohydrate diet, it might be easier for them to sort of go via sweeteners in the way that methadone would be a step down from heroin, as we always say. So in a harm reduction model, it may be okay, and we've seen people do it, haven't we, where they've taken the step to reduce the sugar by going via sweeteners. But I personally would always counsel that the ultimate goal is this real food diet without sweeteners when they can manage it. And I know for myself personally, sweeteners were just as hard to quit as sugar, and it took me a long, long time. Things like sugar-free gum and things like that were incredibly addictive to me. So yeah,
Thank you.
Say anything about sweeteners?
That's fine. I'm going to move on to dealing with barriers, actually. So dealing with barriers now, both related to healthcare professionals, but also to patients. And staying with you, Jen, we have a number of gaps in our knowledge at the moment. It's been pointed out to us by the WHO when we made our application a couple of years ago. Do you want to tell us a little bit about them, but also thinking about the other barriers that have been touched upon here already in the conference, in these 10-minute appointments, this resignation, this hopelessness, it's too hard, it's never going to work, people aren't going to do this, when we talk about abstinence in food addiction treatment.
Yeah, so in terms of gaps in our knowledge, obviously there are massive gaps, and it's partly because this isn't a recognised condition, therefore research isn't funded. So a lot of the research, there is a lot of research, an increasingly number of papers being published every year in this space, but it's much easier to get research funding for recognised conditions. So that's would really help if we could get that. So our paper was the first internationally looking at a treatment approach to food addiction. So we obviously need a lot more trials on treatment interventions and comparing different interventions. Ours was an audit. Again, it wasn't we didn't have a control group. So we need more on treatment protocols. That would be the main focus, really, I would say.
We need to crowdfund, as Helen's doing.
Mm-hmm. There's all kinds of different aspects of research that we're going to need going forwards.
Yeah. And what about dealing with barriers actually at the coalface?
At the coalface. I mean, I think education is really important, and obviously that's why we're going to be talking in a moment about the work that we're doing to provide courses for healthcare professionals so that they can recognise it when they see it in the clinic. Not necessarily that they need to be able to treat food addiction themselves, but they know how to speak to people about it and where to refer them on. I think that's a big part. And then I think the other part is just getting the word out to the general public that we feel this is a legitimate condition. And a bit like when you and I finally realised that this was a good explanatory model for our own behaviour, I think there'll be people out there who go, oh my goodness, yes, that, you know, that's me, and all the pieces fall into place. And then they would know that there would be somewhere that they could come for quality information and support.
Yeah, lovely. Ali, do you want to add anything to that? How we deal with barriers? You're dealing with them every day.
Plenty of barriers, isn't there? I mean, one of the things that I did want to comment on a bit is about, you know, the need for evidence and the idea that, you know, it's not a legitimate disorder. And I think that I struggle with the idea that there's a need, you know, the narrative that we need more and more evidence for something that, I mean, one of the things that we could potentially do is collaborate with the food industry. Clearly, they have a lot of evidence for, you know, the right concoction of ingredients to put in the right amounts and what effects they'll have. I mean, they've studied it to the degree where they're able to justify investing huge amounts of money into, you know, a business model that clearly works. The evidence is there, and obviously people have experiences. And so it's very hard to ignore, you know, when it's so prevalent. But I think the other thing that we probably do need to consider is the distinction between processed food addiction and more global food addiction as well. And I think that that's probably the next thing along that spectrum of eating difficulties that's going to start emerging more and more as appetite homeostasis becomes more and more dysregulated and we have more issues. We're going to get, I think, to the stage where more people, and I'm seeing it already, but I think we're going to get to the stage where more people are experiencing, as a result of potentially being, you know, exposed to ultra-processed foods, but have difficulty with being addicted to food in general, and it might be that they just need a longer period of time of, you know, eating normal, you know, whole unprocessed food before that appetite regulation is restored. But I think that that's genuinely a problem that we're going to start experiencing more and more in clinical practice.
Yeah, thank you. I've just been given a 10-minute warning by Sam, so we've got another slide after this, Sam. I want to move on to our final point here on public health and some links to obesity, type 2 diabetes, hormonal issues, mental health, and possibly food policy, if any of you want to comment on that. But I want to start with you, Claire, so if you could pass the microphone. Claire, you need to tell us more about the hormonal interplay, and in particular there was a question that actually came from some of the other panelists here about the link between reproductive health and metabolic health, and this attitude of I only eat like this because of my hormones, I'm on my period at the moment, so that's when I eat like that. And then, really a fascinating question, does the uncontrolled eating drive the hormones? Or is it the hormones that drive the uncontrolled eating?
Well, if anyone knows the answer to that, you can let me know. Well, you know, I found what Ben was saying yesterday, and he was talking about how the ovaries are so highly sensitive to the insulin, and so that reproductive health being connected to metabolic health. But of course, it's not just the ovaries, you know, it's not just women that are going to struggle there, it's also the estrogen receptors in men. So when we start to look at this, I kind of see that there's these 4 areas, and what we get as coaches that you don't get in clinical experience is we get time with our clients. We get people who are really self-motivated, coming along, paying for sessions, and we have time, so we can break this down and go on a journey with them where we can explain all of this. It's not just, okay, well, I'm a psychiatrist and I'm doing great stuff and I'm dealing with this here and this is the answer to your problem here. We get to look at this from a very whole health perspective. And so when we can look at the interplay between the blood sugars and the stress hormones, the interplay of the blood sugar hormones and the gut, the interplay of the blood sugars and the reproductive health, and how that all goes together, and educate people, they can then make those informed decisions. And actually then the 4th part of that is when we have time to do emotional coaching with them, to teach them self-worth techniques, to teach them what sovereignty actually is and what self-awareness looks like and how they're actually responding to triggers. When it's dealt with in this, it's a longer journey and it's more relaxed, and it's the gift that we have as coaches. that's when we can start to really unpick it. So whether it's what comes first, who knows, because of the society that we're growing up in. But ultimately, it's just about identification and understanding and educating people on, you could choose the cake or you could choose the wheat-free pork scratchings. And if you choose the wheat-free pork scratchings, that's going to help with this, 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 this. And I don't know about anybody else, but one of the things I love the most is when we've done just a little bit of education with someone and they come in and they go, oh, well, I knew my blood sugars were off because I felt like this. And then I go, great, because it's not about us fixing this problem in you. It's actually about you recognizing there's a problem and how you can help yourself.
Yeah, beautiful. So on that last note there of fixing yourself, what about fixing this from a public health perspective? I'm going to ask each one of you just for a quick summary one-liner. If you were so for those of you who are British, if you were the Prime Minister, those of you Georgia, if you were the President, what would you do? What would you do now? Do you want to start, Claire?
For me, it really starts with teaching good self-esteem and autonomy to children so that they are less susceptible to advertising.
Oh, that's a good answer. This question always makes me think of David with his little stickers. So he's got a fantasy of having a load of stickers printed which say, sugar is certain death and little skull bones. And he's going to go round the supermarkets just sticking it on. So if you ever go into Tesco's and see those little stickers, you'll know he's been. So I think that would be a health warning on the Krispy Kremes or something like that. Yeah. Not that that necessarily works with smoking, does it? But we'd feel better.
I think just, well, you know, in the White House in the United States, there have been past efforts by people in the White House to emphasize healthy eating plans. It's just that I think that we don't always have the correct information about what a healthy diet is and what that looks like and what children should be eating and not eating. And I think just a public health education campaign to help people understand the difference between a food and a non-food would go a long way towards, especially with children. I don't think most parents realize. I mean, a lot of parents really believe that they are feeding their kid in a healthy way because it's a whole grain whole grain cookie or what have you, or it's all 100% juice box. We have to really help them understand that they think they're making the healthiest choices, but they're harming their children without realizing it. And so, better education across the board for difference between food and a non-food.
Ali, that's beautiful, Georgia. I want to add to that. When I first came to the UK and had a mother present to me proudly her 5-year-old's lunchbox with all her 5 a day, and it was 5 packets of sweets, all of them with the labelling, one of your 5 a day.
Well, that's fascinating there, because my comment was, you know, if I could do one thing, I would just relabel foods appropriately to say exactly what they are. And I think that whilst it's been useful to have the term ultra-processed foods enter our lexicon, I think the use of the word food is probably inappropriate. And so I think that, you know, if we were to relabel ultra-processed foods and actually name them as what they are, which is recreational drugs rather than foods, that's the policy I'd make.
Beautiful. Thank you. So that's not working. Can't make it work. Okay, so, sorry?
You can just say no.
Yeah, no, works. Yeah. Whoops. Can you go back? Thank you, thank you. Okay, just very quickly, those of you who are interested in more information about this, please either go to the website as shown on the screen behind us, or scan the QR code. I'm reliably told it's in your welcome, in your little goodie bags. As Jen was saying earlier, we are about to launch some hopefully accredited programs for health professionals. We are also working on programs for the general public. All of them, it's a combination of live, online and self-study material and support groups. And the first of them is going to be launched next month. And there I want to bring in Ellen Calto. Where are you? We are so, there she is. Some of you were introduced to Ellen yesterday. She's a much appreciated trustee of the Public Health Collaboration, but she is also our new operations manager for the food addiction resources. So thanks to Ellen, we are going to be able to launch these online courses and online access to these courses as of next month. Thank you, Ellen. And then Jen, do you want to tell us about our regular intensive weekends?
Yeah, so twice a year, Heidi and I go to the Lake District and we host an intensive weekend. It's the course that we did as part of the research that Georgia was talking about. We coach people through all that information in a weekend in a lovely setting, and all profits go to the Public Health Collaboration. So if you yourself or any of your patients are interested in working with us, really intensively, the next course is in November, and there's also 6-month follow-up. So it's not that we get the course and abandon people, and they can become part of our far community and attend our support groups. So you can find out more on the website.
So on that note, a huge thank you to my panel for all your helpful comments and insights.
Hello there, my name is Sam Feltham and I'm the Director of the Public Health Collaboration. Now, before we get into this absolutely brilliant panel, we wanted to thank Dr Jen Unwin and Heidi Giaever for their leadership and voluntary work within and beyond the PHC to build awareness for food addiction. For more information about their work, get in touch or even get involved, please go to the website www.the-chc.org or email contact@the-chc.org. Thank you very much. Enjoy.